Welcome back. I'm an emergency doctor actively working at the emergency department of my hospital. In this Doctor's Corner series, we'll dive into lesser-known approaches and hidden strategies to help the people with critical illnesses. You can subscribe if you want to learn the latest news and healthy solutions about your health. Let us begin with a simple command. Stop treating chronic fatigue as laziness, weakness, or poor motivation. Treat it as a signal that needs structure. Why? Because in many people with long-lasting fatigue, especially those with myalgic encephalomyelitis/chronic fatigue syndrome, the body does not respond to effort in the ordinary way. A person may do something small today. Answer emails, take a shower, attend a family event, walk through a store, and then feel worse tomorrow or even 2 days later. How can anyone manage a condition like that without a plan? The key idea is this: do not chase energy, manage it. Do not wait for collapse, predict it. Do not live by impulse, live by a flexible plan. Medical literature has become much more careful about this illness. The National Academy of Medicine's diagnostic framework emphasizes that ME/CFS involves a major reduction in previous activity, post-exertional malaise, unrefreshing sleep, and either cognitive impairment or orthostatic intolerance. Post-exertional malaise means symptoms worsen after physical, mental, emotional, or sensory effort that would not have caused trouble before the illness. So ask yourself, why is making a plan powerful? Because chronic fatigue often steals predictability. A plan gives predictability back. It does not promise a cure. It does something more immediately useful. It helps the person avoid avoidable crashes, identify personal limits, protect necessary energy, and communicate needs clearly to family, employers, schools, and clinicians. Now, build the plan in layers. Do not begin with exercise. Do not begin with motivation speeches. Begin with observation. First, track the pattern. Use a notebook, a phone note, or a simple chart. Record sleep, meals, pain, dizziness, concentration, emotional stress, screen time, social time, physical tasks, and symptom changes over the next 24 to 72 hours. Why 72 hours? Because post-exertional worsening is often delayed. Symptoms commonly worsen 12 to 48 hours after activity and may last for days or weeks. If the crash is delayed, memory alone becomes a poor guide. Track it. Make the invisible sequence visible. How does this help? It turns "I feel terrible for no reason" into "I had a long phone call, skipped rest, stood in line, cooked dinner, and crashed the next day." That is not blame. That is data. And data allows protection. Second, identify the energy envelope. Think of daily energy as a limited clinical resource, not a personality trait. Ask, what can this person do on a bad day without worsening? What can they do on an average day? What activity seems small to others but costly to the patient? Showering, reading, noise, decision-making, standing upright? The CDC describes pacing as balancing activity and rest to avoid post-exertional malaise, and it specifically recommends finding personal limits for both mental and physical activity. It also notes that diaries can help identify these limits, especially early in the illness. Now give this command: stay below the crash line before trying to expand anything. Why? Because repeated overexertion can create a push and crash cycle. The person feels slightly better, tries to catch up, overdose it, crashes, rests for days, then repeats the cycle. Planning interrupts that loop. Third, divide the day before the day divides you. Break tasks into fragments. Sit while brushing teeth. Sit while preparing food. Put a chair in the bathroom. Use delivery when possible. Batch decisions. Place rest before and after appointments, not only after symptoms explode. If grocery shopping causes a crash, do not call it just shopping. Call it a high-cost activity and plan around it. Ask, how can one ordinary task become safer? Reduce standing time. Reduce sensory input. Reduce speed. Reduce multitasking. Reduce emotional pressure. add recovery windows. This is not giving up, it is engineering the day around the body's actual capacity. Fourth, make a flare-up plan while the person is not in a flare-up. Write it down. What should be cancelled first? Who should be contacted? What meals are easy? Which medications are already approved by the clinician? What symptoms mean urgent medical review? What signs mean the person must reduce activity immediately? NICE guidance for ME/CFS emphasizes energy management, warns against general exercise advice such as simply telling someone to go to the gym or exercise more, and advises against fixed increase graded exercise approaches because they can worsen symptoms in people with ME/CFS. Why does that matter? Because many people with chronic fatigue have been told, just push through. But in this condition, pushing through can be the exact wrong instruction. Give a different command. Respect the stop signal early. If light, noise, conversation, standing, reading, or walking begins to produce warning signs, stop before the body forces a stop. Fifth, prioritize the most disruptive symptom first. Do not attempt to fix everything in 1 week. If sleep is chaotic, begin there. If dizziness on standing dominates, address that. If pain prevents basic function, target pain. If cognitive fog makes planning impossible, simplify the plan. The CDC recommends that patients, families, and clinicians decide together which symptom is causing the most difficulty and treat that first. It also discusses sleep problems, pain, orthostatic intolerance, depression and anxiety, and cognitive symptoms as areas that may need individualized management. How can this be used tomorrow morning? Choose one target. For example, this week we protect sleep timing and reduce morning standing. Or this week we reduce screen time after 7 p.m. and add 2 scheduled rests. Small, controlled changes are easier to evaluate than 10 changes at once. Sixth, separate movement from forced conditioning. The body may still need gentle movement within tolerance, stretching, range of motion work, careful mobility, or brief functional activity. But it must be individualized. Do not prescribe fixed increases just because the calendar changed. Ask, did symptoms remain stable? Did post-exertional malaise occur? Did cognition worsen? Did heart rate stay elevated after minor activity? Did the person need 2 days to recover from one task? Research on pacing is not perfect, but it is clinically meaningful. A systematic review and meta-analysis found that activity pacing interventions can reduce fatigue and psychological distress and improve physical function in chronic fatigue syndrome, especially when delivered as individualized self-management rather than as a rigid formula. So give this command, adjust up, down, or sideways based on the body's response. If the person is stable, the plan may cautiously allow more. If symptoms flare, reduce. If standing is worse than sitting, modify posture. If cognitive work is more draining than walking, protect mental energy as seriously as physical energy. Seventh, use technology carefully, not obsessively. Some patients benefit from heart rate monitoring because it shows when the body is working harder than the activity appears to demand. Why can this help? Because standing, showering, stairs, heat, emotional stress, and conversation can raise physiological load even when the person is not exercising. The CDC notes that some patients find heart rate monitors useful for tracking exertion and preventing post-exertional malaise. But give a warning, do not let numbers become a second illness. Use them as guideposts, not as a prison. If tracking increases anxiety or consumes too much energy, simplify it. The plan must serve the person. The person must not become a full-time manager of spreadsheets. Eighth, make the plan social. Chronic fatigue is not managed only inside the body. It is managed inside a household, a workplace, a classroom, and a medical system. Tell family members exactly what support looks like. Please do not encourage me to push through. Please help me prepare food before appointments. Please understand that if I look fine for 1 hour, that does not mean I am fine for the next 2 days. Ask the family. How can we reduce the patient's energy spending without reducing their dignity? Let them choose, where possible. Offer help without taking over. Protect independence by removing needless strain. 9th, include medical review. Chronic fatigue can overlap with anemia, thyroid disease, autoimmune illness, sleep apnea, medication side effects, depression, infection-related syndromes, dysautonomia, and other conditions. Do not self-diagnose everything. Do not ignore red flags, chest pain, fainting, unexplained weight loss, fever, new neurological symptoms, severe shortness of breath, or rapidly worsening function. Build the plan with a clinician, especially before changing medications, salt intake, fluid intake, or physical activity. And 10th, review the plan weekly. Ask 3 questions. What protected energy? What triggered worsening? What can be made easier? Keep what works. Remove what fails. Lower the demand when symptoms rise. Raise only with caution when stability holds. Why does this approach work? Because it respects the central paradox of chronic fatigue. Doing less at the right time may allow more life over the long run. Planning does not make the illness imaginary, it makes the response intelligent. So, here is the final message. Make a plan before fatigue makes decisions for you. Map symptoms. Protect the energy envelope. Break tasks into smaller pieces. Schedule rest before collapse. Avoid fixed increase exercise plans unless guided by clinicians who understand ME/CFS. Treat the most disruptive symptom first. Use tools only if they help. Involve family. Review the plan often. Why is this beneficial? Because it replaces chaos with pattern recognition. How is it effective? By reducing preventable crashes, improving communication, conserving energy for what matters, and giving the patient a safer way to live with a body that no longer follows ordinary rules. Do not ask, how do I force myself back to normal by next week? Ask instead, how do I protect function today so tomorrow is not stolen? Take that question seriously, write the plan, share the plan, live the plan flexibly. And remember, the goal is not to win a battle against the body. The goal is to work with the body wisely enough to preserve life, relationships, and hope. Stay well, take care of one another, and keep moving forward as one family. I'll see you in the next topic.